Caesarean scar ectopic pregnancy, diagnostic challenges and management options. Okay. So the diagnostic features, whatever we have already discussed, we will skip those slides. Okay. So the incidence is rising due to the increasing number of Caesarean section. Early diagnosis is essential to reduce the morbidity. A high index of suspicion is needed in women with relevant history. Ultrasound is the diagnostic tool of choice. Okay, what are the management options? We have medical management, that is methotrexate. We have surgical management, and we have interventional radiology management also. And what is the comprehensive management plan in cases of Caesarean scar? You need to have a thorough counseling of the patient, needs to have a surgical expertise and access to the blood transfusion. Proper patient selection is critical for successful outcomes. The major risk here included are severe hemorrhage and hysterectomy. So these are the important risks which are involved in management of the Caesarean scar pregnancy. Caesarean scar pregnancy is a rare form of ectopic pregnancy where the gestational sac implants in a previous Caesarean section scar. The incidence is around 1 in 1,800 to 1 in 2,500 of all pregnancies. Remember these values. 1 in interstitial we have seen 1 to 6%. Okay. Scar pregnancy 1 in 800, 1 in 1,800 to 1,000 to 2,500. Okay. And among women with at least one previous Caesarean section, a diagnosis of ectopic is primarily seen in 6.1% cases of estimated CSV. So if you see all ectopic in patients with previous one Caesarean section, the prevalence of scar ectopic will be 6.1%. Okay, so ectopic which are occurring in previous Caesarean section, 6.1% are the Caesarean scar pregnancies. Okay. Coming to the pathophysiology of Caesarean scar pregnancy, this is not asked in the final examination, but just from the understanding point of view, I am going to read this. The exact mechanism of Caesarean scar pregnancy is not well understood. Endometrial or myometrial scarring from previous Caesarean section may predispose to the abnormal implantation. So this endometrial or myometrial scarring is one pathophysiology. Likely mechanism: blastocyst invades through a microscopic tract in the scar caused by the previous Caesarean section. Prior surgery may affect endometrial receptivity, not just due to the presence of the scar. Risk may relate to the size of anterior uterine wall defect. Most Caesarean scar pregnancies cases occur after just one Caesarean section. So number of Caesarean section not directly correlated with the risk. Remember, most of the Caesarean scar pregnancies will happen after one Caesarean section. It has got no relation with the number of Caesarean sections. Okay. And women who had a Caesarean section for breech presentation are at higher risk, possibly due to higher uterine incision, because most of the time these sections are elective sections, and there is an underdeveloped lower segment. The incision may be taken on higher. So what they say that Caesarean section for breech presentation patients are at higher risk of development of the scar ectopic pregnancy. Okay. Now most women will have what is the recurrence? What is the recurrence of Caesarean scar pregnancy? Most will have a normal pregnancy after previous Caesarean scar pregnancy. The recurrence risk is around 3.2 to 5% after treatment with DNC and plus minus uterine artery embolization. Risk factors for recurrence will be like if the uterine segment thickness is less than 5 millimeter, there is a gestational sac bulging into the UV fold, Caesarean section which is performed in the rural hospital, and history of irregular bleeding and abdominal pain in patients prior to Caesarean section pregnancy. So these are the patients in whom the recurrence is likely to occur. Okay. Surgical repair may reduce the recurrence by restoring the anatomy, but recurrence can still occur. So if you repair the scar along with the excision of the removal of the ectopic pregnancy, the recurrence rate will be less, and the overall the recurrent rate is around 3.2 to 5% they have mentioned. Now, what is the classification of Caesarean scar pregnancy? There are main two types, that is endogenic or exogenic. Endogenic or type 1, where the implantation on the scar, the sac will grow towards the cervicoischemic or the uterine cavity. So the sac will start growing inside. Okay, maybe cervical canal or maybe towards the isthmus or the uterine cavity. And the type 2 is exogenic, where the sac is deeply embedded in the scar and myometrium, it grows towards the bladder. Okay, sac may bulge through the thinning myometrium, increase the risk of early rupture. So there is a thin myometrium. Okay, and in 2/3 of cases, the scar thickness is less than 5 mm. There was an EMQ which was asked on this topic maybe 2-3 years back. That is why this topic I'm covering, and really this particular topic is confusing as far as the management is concerned, which management option to choose in that particular scenario. So just understand various principles which we are going to discuss. Up to 13.6% of cesarean section scar pregnancies are likely to be misdiagnosed as inevitable miscarriage or cervical ectopic. So if it is an endogenic, we may confuse this as inevitable miscarriage, or we may consider it as a cervical ectopic pregnancy, and around 13.6 pregnancies are misdiagnosed. And what are the key differentiating features then? Caesarean scar pregnancy will have a fixed sac at scar site. There will be absent sliding sign and good Doppler blood flow, while miscarriage will be irregular sac, low Doppler flow, and positive sliding sign. Okay. Then cervical pregnancy, again, this sliding line here, it will be negative, but the sac is in or near the cervical canal. The cervical balloon, cervix will be ballooned, and below the level of the internal os, you will see the G-sac. Okay, negative sliding sign and good Doppler flow. That is how you differentiate caesarean scar pregnancy from these two. Then what is the risk? In misdiagnosis, surgical evacuation can lead to severe bleeding and the hysterectomy. So these are the very risks which are involved in management of the CS scar pregnancy. Okay, and MRI can assist when ultrasound findings are unclear, especially in later gestation. So you can go ahead with the MRI. Okay, so if they ask the ultrasound is suspicious of ectopic pregnancy, C-section ectopic pregnancy, what will be the next investigation? You may select MRI also. Okay. Then coming to the diagnosis of caesarean scar pregnancy and the role of imaging. Ultrasound is the primary diagnostic tool for caesarean scar pregnancy. Combined transabdominal and transvaginal ultrasound offers high diagnostic accuracy. So you have to do TVS and TAS also, as we discussed in the beginning. So transabdominal scan provides panoramic view of the uterus and the bladder, especially useful in the later gestation. Okay, so TVS plus TAS, that is the initial screen. Okay, then typical ultrasound features will be G-sac attached to or embedded in the caesarean section scar. Presence of yolk sac, embryo, and cardiac activity may mimic a normal pregnancy, but there will be prominent circular vascular flow around the sac on color Doppler. Okay. Now, further imaging, what we can do is a 3D TVS you can do with power Doppler, or you can carry out MRI. Okay. Now here there will be confusion if you are asked about the next step after the 2D. You have done the normal TVS and you are suspecting the scan CS scar pregnancy. What will be the next step? Whether it is a 3D ultrasound or whether it is an MRI. So this option is going to be little confusing. So you need to read the question carefully, and you need to understand this. 3D ultrasound with power Doppler provides enhanced imaging of the ectopic mass. It helps to identify peritropoblastic vascular flow and measure myometrial thickness, not routinely required but useful in selected cases. Okay, so what I have understood, it definitely gives some enhanced imaging, but not routinely required, but not useful in but useful in selected cases. Now come see what they say about the MRI. It is helpful when the ultrasound is inconclusive. Example, in presence of fibroids or late gestation, offers additional anatomical clarity. So this offers more anatomical clarity. And if your question mentions the word ultrasound is inconclusive, definitely select the MRI. Okay, if the word inconclusive is there, otherwise there might be little confusion which one to select. Okay, is it clear? We'll go ahead.
Yes, sir.
So yeah, key principles of caesarean scar pregnancy management. There is no consensus on preferred treatment modality. Treatment should be individualized based on patient stability, gestational age, SCG levels, scar anatomy, and type of cesarean section pregnancy, whether it is endogenic or exogenic. Okay, so all these factors, what is the stability of the patient, how much is the gestational age, SCG levels, and all these factors will decide what is going to be the mode of management. Aim is to end the pregnancy early so that we can preserve the fertility. All treatments will carry the risk of hemorrhage and the hysterectomy, that also we have already discussed. So various modalities of treatment which are available for management are, one is a medical management with the help of methotrexate. Now this methotrexate can be given systemically or can be injected locally also, or it can be combined both. You give simultaneously local as well as system. That is what is the combined methotrexate. Okay. What is the indication? The patient should be hemodynamically stable. It should be early gestation. The beta HCG value should be low. It avoids surgery, but it requires long follow. And the resolution of the beta HCG is very slow. When you go for medical management, no, it is slow. Now, second is a embolization techniques. We have uterine artery embolization you can do. You can go ahead with the chemo embolization also, bilateral uterine artery chemo embolization. It may be performed alone or adjunct to medical or surgical methods. It controls bleeding and preserves the uterus. Then you have surgical management, in which you have a D&C. Then laparoscopy or laparotomy, you can perform resection, you can do basically laparoscopically or laparotomy. Then hysteroscopic resection also you can do, and transvaginal route they have mentioned. Then this is suitable for higher SCG, larger mass, thin myometrium, and failed medical treatment. So when you are given a scenario, you look at all these options, like what is the SCG value is given, what gestational age they have given, okay, and then select the appropriate. And it will offer immediate resolution and potential scar repair. You can do the scar repair also, because you need to prevent the recurrence, no? So the scar repair is going to be important, and that can be when you are managing surgically. It is you are able to do both removal of the ectopic also, and you are able to do the scar repair also. Now coming to the medical management. So in medical management, the drug of choice is methotrexate. So you can give it systemically also. You can give locally, or you can combine it both. Okay, when you give systemically, it is suitable for beta HCG less than 5,000 and gestational age is less than 8 weeks. The alone given systemically, 41% success rate without additional treatment. And what was the success rate of medical management in ectopic pregnancy in the previously last session we discussed? Single dose of methotrexate is successful in dash percentage of, this is a SBA. Yes, Dr. Sinchana, anyone, Dr. Indrani, or anyone? You remember success rate of single dose of methotrexate? No, 65 to 95%.
95.
65 to 95%. Okay. So my session, you just don't have to listen. You, whenever you are at work, no, just put this in earbuds and start listening when even at work also. These values you will remember. Okay. So here it is a 41% success rate, okay, with methotrexate when used systemically in cesarean scar pregnancy. Remember, the success rate is little lower than the other ectopic, okay, or tubal ectopic. Counseling needed, prolonged follow-up, risk of surgery. Now, if you give locally or combined, they have given a higher. Combined systemic plus the success rate they have mentioned is higher, 74%. Now, locally, what can you inject? You can give methotrexate, you can give KCl, you can give etoposide, hyperosmolar glucose. The procedure is that you aspirate the GSAC, inject methotrexate under ultrasound guidance by transvaginal method, which is preferred, and resolution time will depend upon the sac size and SCG levels. Okay, so you can inject locally also, or you can do combine also, that is local plus systemic, and the success rate will be more, up to 74%. Okay. Another is a chemo embolization, will depend on the availability of the facility in which uterine artery embolization along with methotrexate you can use. It will reduce the bleeding during and after the surgery. Then uterine artery chemoembolization with methotrexate reported 97.8% success in one series. There is no direct comparative data with other treatments. What are the clinical tips in management of CS scar pregnancy? Remember, if it is an exogenic Caesarean scar pregnancy and having thin overlying myometrium, that is less than 2 millimeter, okay, that is exogenic, then prefer surgical option. Okay, so if you have a exogenic CSP, While if you have an endogenic CS scar pregnancy and it has got a better myometrial support generally, okay, 2 millimeter or more, then DNC may be appropriate. Okay. And the combination approaches like methotrexate plus uterine artery embolization, methotrexate plus surgery often improves. Scar defect repair during surgery will reduce the recurrence risk. This also we have already discussed. Okay. So just remember surgical option if it is exogenic, and DNC may be appropriate if it is an endogenic CSP. Okay. So what are the options, surgical options which are available with us? That is, one is a suction curettage you can do. It is suitable if it is an endogenic CSP and myometrial thickness is 2 millimeter or more. Okay. Better to do in the ultrasound guidance. Risk of incomplete evacuation and bleeding is more with this. Then Foley's catheter and Schroeder's suture is there. It is adjunct to reduce bleeding and during DNC. Schroeder's suture tied post evacuation is effective. Then laparoscopic and open resection. This is suitable for exogenous CSP and thin myometrium. It is preferred for defect repair and definitive treatment. Okay. So if you have a exogenous, no, better to go ahead with the laparoscopic resection along with the scar repair. Okay. Then another option is a hysteroscopic resection, especially when you have a remnant mass post methotrexate, or it can be considered as a primary treatment also. It can be combined with laparoscopy or uterine artery embolization. Then transvaginal resection, alternative to laparoscopy, allows defect closure and similar recovery outcomes. Okay, so these are the various options, and that is why which option to select will depend upon the scenario which is given to you. Okay. Then combined and sequential management. Now there is a difference between the combined management and the sequential management. In combined management, there are two techniques with a very short interval or at the same time we are using, while in sequential there is a more gap between the two interventions. Okay, so in combined management involves using more than one modality, that is for example uterine artery embolization plus methotrexate. Okay, uterine artery embolization will reduce the risk of the bleeding during suction evacuation, while methotrexate will help to absorb the residual trophoblastic tissue. So this combined approach will reduce the bleeding, the chances of hysterectomy will be reduced, and recovery will be better. Okay, so they have a different mechanism of action. Okay, then typically evacuation is done 24 to 48 hours after chemoembolization. So first is a uterine artery embolization which is carried out, then do the 24 evacuation 24 to 48 hours. This is useful in moderate to heavy bleeding cases. Uterine artery embolization complications, there can be fever, pain, infection, amenorrhea, premature ovarian aging, and residual tissue after embolization can rupture or it can recur also. So these are the complications here after the uterine artery embolization. Then what is sequential management? One method followed by another after a time interval. Okay, you give methotrexate and later on follow it with surgery. So used when medical treatment fails or symptoms persist. Resolution may take up to 6 months. Okay, if the mass is bigger, it may take 1 year also. The risk will include infection, AV malformation, prolonged morbidity. Surgical intervention may include evacuation or resection, preferred when Caesarean scar mass is large or persistent. Okay, good outcomes with surgery 7 days post-op with methotrexate. Some needed further intervention, and SCG levels don't predict blood loss accurately. Okay, so that is what about the sequential management. There is a very minimal role of expectant management. The high risk is 67% will require further treatment if you go ahead with the expectant management, and 29% may require hysterectomy. It is suitable for non-viable Caesarean scar pregnancy when the beta SCG is declining and the women are asymptomatic. So these are the only patients. So you look at the scenario, what is given to you, and select the best option. Okay, so even expectant management is also available, but in a very selected cases, it is not recommended for viable Caesarean section scar pregnancy. If it is viable, this option is out. Okay, rarely used when patients decline termination despite risk. Must involve clear counseling and close monitoring. Plan for early Caesarean delivery if the pregnancy continues. Okay, so that is what they say about the expectant management. And second is a heterotopic pregnancy with Caesarean scar pregnancy. That means there is a one Caesarean scar pregnancy and another is a intrauterine pregnancy. Then how to manage? It is rare. One sac is in the scar, other is in the uterine cavity. It is possible to inject KCL into the Caesarean scar pregnancy and continue the intrauterine pregnancy. Exogenous Caesarean scar pregnancy can be removed via laparoscopy or laparotomy, and risk of bleeding and loss of normal pregnancy will always remain. Okay. Then which option to choose? So what are the key points? So it is always individualized based on patient factors. Expectant management generally not recommended except in rare cases, what we have discussed. Then medical management for suitable for stable and asymptomatic women. It is most effective if the gestation is less than 8 weeks and beta HCG is less than 5,000. Intralesional methotrexate plus sac aspiration has got higher success rate. Surgical treatment is preferred for symptomatic women and those who decline medical management. Again, endogenous Caesarean scar pregnancy, surgical evacuation or hysteroscopic resection is preferred. Exogenous Caesarean scar pregnancy, consider surgical resection with a defect repair. Okay. Prefer transvaginal or laparoscopic surgery or laparotomy if feasible. Use combined or sequential treatment for longer gestation and failed or incomplete initial treatment. Okay, so these are the key points about this particular article in management of the Caesarean scar pregnancy. Now, what about the follow-up and future pregnancy after the Caesarean scar? Okay, ectopic. So SCG decline and mass resolution take longer with medical than the surgical management. Expect initial SCG rise after the methotrexate due to tissue necrosis and bleeding. Provide adequate counseling about the duration, complications, and need for further intervention. Treating center must have emergency facilities. Scar defects may require resuturing before the next pregnancy. Successful pregnancies are known after the Caesarean section pregnancy. Recommend early ultrasound to rule out recurrence. Monitor for morbidly adherent placenta. And all reported cases are delivered by Caesarean section. So this is about the follow-up of these Caesarean scar ectopic pregnancies. So that finishes our second TOG article. Thank you.